Welcome everyone to today's webinar. This is Lindsay Dunn, Managing Editor with Health Forum, publisher of Hospitals and Health Networks, and I'm pleased to be moderating today's webinar, How to Decrease Healthcare-Associated Infection Costs by 30% in 2 Easy Steps. Healthcare-associated infections, or HAIs, are a threat to patient safety, we all know, and at any given time, about 1 in 25 hospital patients have an infection related to care, according to the CDC. These infections lead to the loss of tens of thousands of lives and cost the U.S. healthcare system billions of dollars each year. Now, many factors increase the risk of HAIs, including catheters, surgery, injections, just being in a healthcare setting that is improperly cleaned and disinfected, communicable diseases, and the over or improper use of antibiotics, and that's just to name a few. The prevention and reduction of HAIs is a top priority for both the U.S. Department of Health and Human Services and really all healthcare providers. So today's webinar will feature a strategy to reduce HAI costs that is supported by data from a 13-month microbiome study on patient clinical outcomes at a new 270-bed hospital in north central United States. You will be hearing from Dr. Stephanie Taylor, CEO of Taylor Healthcare Commissioning, Tracy Hannigan, Principal Mechanical Engineer of Kaufman Engineers, and Colin Toffey, MD and MBA candidate at the School of Medicine and Tuck Business School at Dartmouth. So our webinar will begin with a presentation by Dr. Taylor, Mrs. Hannigan, and Mr. Toffey, and will conclude with a 10 to 15-minute question and answer session. All lines have been placed in listen-only mode, so to submit a question to be addressed during the Q&A, please click on the Ask a Question button located below the presentation. Simply type your question in the box and hit Submit. Questions can be submitted at any time during the presentation, and we'll answer them all, or as many as we have time for, during the Q&A time at the end. Throughout the presentation, we will also be pushing out 2 poll questions, so we encourage you to answer the questions when they are pushed out. And finally, at the end of the webinar, we will be pushing out a survey for your feedback of today's presentation. Your feedback is, of course, important to us, so we encourage you to complete that survey. So let me briefly introduce today's speakers. Dr. Stephanie Taylor is the CEO of Taylor Healthcare Commissioning. After working as a physician for many decades, Dr. Taylor obtained a master's in architecture as well as an infection control certification. Her lifelong commitment to patient care includes in focusing on improving the healthcare physical environment and clinical work processes to help patients heal quickly and save hospitals valuable dollars. Dr. Taylor is a graduate of Harvard Medical School and Norwich University, and she has numerous research publications in Nature, Science, and other peer-reviewed journals. Our next speaker is Tracy Hannigan. She is principal at Kaufman Engineers in Spokane, Washington, where she manages the mechanical department. Her 20 years of experience includes design of commercial facilities such as laboratories, hospitals, schools, data centers, zoos, and office buildings. Ms. Hannigan is currently the chair of the ASHRC Technical Committee on Laboratories, secretary of the Healthcare Facilities Technical Committee, and chair of the Subcommittee on Infectious Diseases. She has extensive experience in biological safety laboratories, infection control during hospital construction, sustainable design, and critical room airflow patterns. And finally, M. Colin Toffey is completing his 5th year at the Geisel School of Medicine and Tuck School of Business at Dartmouth for his MD MBA degree. He has worked in many capacities across healthcare delivery systems throughout New England and the southern U.S. His areas of focus include managing operational costs to maintain operating margins in the face of falling reimbursement, as well as recommending hospital growth strategies. He has also implemented a new integrated care delivery model and consulted on multiple biotechnology startup companies which are bringing healthcare data analysis products to the market. So with that, it is now my pleasure to turn the floor over to Mr. Toffey, who will begin our presentation.
Well, first I'd like to thank everybody for attending, as well as the Health Forum for hosting our presentation. Today we're going to be talking about HAIs and an important element of environmental precaution that's largely ignored. That's the indoor environment. We'll discuss some research around this and then go into some actionable items to implement this strategy and as well as the financial impact. These are our speakers again today, as we've been introduced. To start, we'll give a quick background on the current landscape in healthcare with regards to quality and reimbursement. And then we'll get into the meat of the presentation and discuss the impact of the indoor environment on pathogens as well as patient defenses. We'll describe some perceived barriers to managing the indoor environment and some key considerations to be aware of. And finally, we'll talk about some necessary actions and key steps to actually address this, as well as the financials behind that. So getting into the current healthcare operational landscape. Hospitals today have a massive amount of pressure with their operational performance, both due to falling reimbursement and additional costs, such as penalties. You can see in the upper left-hand corner, hospital Medicare margins have been falling pretty significantly over the past 10 years. This is largely due to national efforts to control healthcare spending, which leads to reduced reimbursement, as well as rising healthcare costs due to disease burden, as well as healthcare technology. This leads to the setting that hospitals cannot afford to provide inefficient or expensive care. Additionally, penalties have been increasing facing hospitals over the last several years due to the ACA and the AAA. As you can see in the lower left-hand corner, over half of hospitals have been exposed to penalties in 2013, and this is going to continue to rise. Hospitals will see even more of the revenue at risk from quality penalties. On the upper left-hand corner, you can see in the next few performance years from 2016 to 2020, the maximum penalty will increase from about 4% to 9% of hospital revenues. In the past, this has been due to several quality organizations, the Meaningful Use Program, the Physician Quality Reporting System, and the Value-Based Purchasing Modifier. The MIPS, the Medicare Incentive Payment System, will group all of these under one category, starting in 2017 on the breakdown that you can see in the upper right-hand corner. However, in reality, these penalties only represent a small fraction of the costs associated with quality breaches. The additional treatment costs associated with medical errors, as well as the lost revenue opportunities from filled beds in the hospital, also contribute. A 2008 report calculated the annual cost of medical errors in the U.S. to be $19.5 billion. And hospital-acquired infections represent a large category of this. Also, when one incorporates the value of life lost into medical error, some estimate that number to rise to almost $100 billion annually. However, this number is not commonly cited due to some conflicts surrounding valuing life. The hospital-acquired infections are alarmingly common, and they do create significant financial burden. In the upper left-hand corner, you can see the annual incidence of the 5 most common hospital-acquired infections in the U.S. These are ventilator-associated pneumonia, urinary tract infections, surgical site infections, Clostridium difficile, and central line infections. In the lower left-hand corner, you can see the financial impact of these. And when you combine them to the right, you can see the total financial burden on the U.S. of these hospital-acquired infections. In 2013, it approached $10 billion. So in order to address these, there are certain containment efforts. Most of them today are process-oriented and very disease-specific. This is coming off of data from the CDC as well as the World Health Organization. On the left hand, you can see the 5 most common infections, hospital-acquired infections, and then you can see the precautions that are emphasized with the primary emphasis being the blue ones. Most of these are process-oriented, so what the clinicians can do, good hand hygiene, practicing sterile techniques, as well as not performing unnecessary procedures. And there are very few environmental precautions that are emphasized today. With Clostridium difficile and surgery, there is some indoor air control as an environmental precaution, but it's only secondarily emphasized. However, in reality, airborne factors affect most of these hospital-acquired infections. They all have shown to have an airborne presence in humidity, airflow, and air filtration and recirculation will have an effect on this, as we'll learn about in this presentation. However, previous research has really neglected to look into these factors, and that's something that we hope to change today and in the future.
Hi, everyone. This is Dr. Taylor speaking now. I'm really excited to be talking with you about this subject. So as Mr. Tassi has said, HAIs are a huge problem, and we need to ask, what else can we do to help protect patients? So with that question in mind, we undertook a study, a 13-month study in a teaching hospital, about a 280-bed hospital in north central United States. And we monitored patient rooms over a little more than a year, starting with the brand new facility. We concurrently mapped the bacterial communities and tracked patient infections in the monitored rooms. So the conditions that we were really interested in were ones that we thought could impact pathogen or microorganisms that cause disease, could impact their growth. So we looked at temperature, humidity, CO2 levels in the patient rooms, lux, which is lighting. We looked at carbon dioxide, outdoor air, ventilation, hand hygiene, and traffic in and out of the patient rooms. So before I move on to actually show you what we found, I would just like each of you to think for a moment what indoor parameter you would guess, if any, were related to patient outcome, and maybe jot it down. So moving along, our findings showed that of the 8 parameters I just mentioned that were significantly related to patient outcome, it was the indoor air relative humidity, which correlated with patient infections. So if you look on this graph, you'll see on the x-axis, you move along during the seasons over which the study was done. And on the y-axis, we have both the relative humidity of the patient rooms and over on the right, the number of HAIs. So it's pretty clear that as the indoor air relative humidity approached 42%, the number of patient infections diminished. This is a really exciting and important finding. So how in the world could indoor air relative humidity be so important? Let's take a look at that. So we're going to talk about transmission of the pathogens. We're going to talk about the very infectivity of them, as well as patient defenses and also surface cleaning. So to begin with, as I just said, the indoor air humidification, or as I sometimes call it, the indoor air hydration, just to get away from some of the negative connotations people have with humidity. Proper indoor air hydration, which means maintaining your room or your air from 40 to 60% relative humidity. And just to remind you, relative humidity is the amount of moisture in the air relative to 100% saturation. So if you're in a cloud or on a very foggy day, you have 100% or nearly 100% relative humidity. So the closer you get to that, the higher the indoor humidification. But anyway, so we're looking at the way relative humidity impacts infections are through the controlling the spread of the pathogens, decreasing their infectivity, enhancing our own natural physiological barriers and defense mechanisms. Proper humidification can decrease symptoms to environmental allergies and enhance pre-existing infection control protocols for hand hygiene and surface disinfection. So let's take a look first at what happens to droplets that are coughed into the environment. So your mother-in-law comes to visit you in the hospital and she has a nasty strep throat infection. She coughs and expels about 40,000 infected droplets. Those come out of her mouth at about, with a diameter of about 100 microns and very quickly shrink to reach moisture equilibrium with the air in the room. So if you have a dry indoor air situation, those droplets are going to shrink very quickly within seconds to about half a micron diameter. At that point, those tiny droplets, which generally we call droplet nuclei, can be transmitted through the air for great distances over long periods of time. So kind of putting it together, here she comes and coughs, and those infected droplets shrink. They can be disseminated through the ventilation ducts. They can recirculate directly through the air. They can land on surfaces and in dry and turbulent air, be resuspended, and through all of these mechanisms, they can reach a patient which has no initial contact with her. Conversely, if you have properly hydrated or humidified indoor air, those droplets don't shrink so rapidly, and they don't reach such small sizes. They settle and can be cleaned by the existing surface disinfection or hand hygiene steps that people take in hospitals. So the bed rails, the trays next to the bed, all of those surfaces will be cleaned and will stay clean. In addition to decreased transmission, many viruses and some bacteria, and the research on this is still in progress, have a really fascinating response to the indoor air relative humidity that humans find comfortable and healthy. So studies have shown that between 40 and 60%, or in this slide it's showing 30 to 50%, viruses are actually less viable, meaning they're less infective in this healthy range. The same is true of many bacteria. And so another effect, which is very, very important, is that proper indoor air humidification helps maintain our natural physiological defenses. And by this I mean that our skin and our respiratory tract, from our nose, sinuses, mouth, throat, trachea, bronchial tubes down into the depths of our lungs, have built-in mechanisms to keep us from getting sick. And for example, we have in our respiratory tract, we have a thin mucus layer, which in properly hydrated air is able to trap particles and pathogens when they're still up in our nose or mouth, and thereby we can swallow them and put them down in our stomach where they're inactivated. Further down in our respiratory tract, there are these little hairs called cilia, which are constantly washing upward, and this is another mechanism to prevent infectious particles from reaching the delicate tissues such as our lungs and eventually our bloodstream. So with properly hydrated, humidified air, these defense mechanisms are very functional. When the air is very dry, the mucus gets thickened, the cilia stop working, you increase susceptibility to infections, increased bronchospasm, asthma, and reactive airway disease. Not a good situation with the dry air. So all of us are vulnerable to these effects. Some people are especially vulnerable. For example, patients in the hospital are very vulnerable to the deleterious effects of dry indoor air. People on opposite ends of the spectrum in terms of age are vulnerable. So babies who have more transdermal fluid losses, who have less control over what they drink, how heavily they're clothed, and elderly people who have thin skin and again may have restricted access to fluids. So is this new information? And actually some of it is new, such as the data from the study. However, some of it's been known for quite a while. And as a matter of fact, in 1975, Dr. Dimmock, who was actually doing biological warfare research, said that moisture content may be the most important environmental factor influencing the survival of airborne microbes. So this has been known for some time, at least some aspects of why indoor air humidification is so important to decrease infections and to maintain our health. We're going to have this question, and then Ms. Hannigan is going to talk more about why we're not all managing our buildings using these parameters. Thank you.
Great. Thank you, Dr. Taylor. This is Lindsay Dunn with H&H Ennigan, and I'm here to kick off our first poll question, which should appear on your screen now. So please respond, does your facility monitor and regulate relative humidity? Not sure. We follow ASHRAE guidelines. No, the only good humidifier is one that is shut off. We have humid outdoor air most of the year, so we do not worry about the few dry months. So we'll give you a few seconds to respond. If you can go ahead and get those responses in. And now we'll go ahead and show the results to everyone. And it looks here that a good majority of you are following the guidelines, though certainly about a quarter not sure. So thank you for that information. And now we'll turn it over to Mrs. Hannigan for the remainder of the presentation.
Hey, thanks very much. Delighted to be here today and be able to speak with you. We're going to talk for just a few minutes about some of the barriers to good indoor air management. There's some misconceptions that are out there and some challenges to operating and maintaining buildings with a great thermal hydration going on, and there are costs associated with doing this that might be a little bit counterintuitive. So one of the things to think about is that mold, it kind of has that negative connotation mold comes to mind when you think about humidity, and we think about having a humid air and people are sweating and stuff is growing, but it's important to realize that mold and fungi don't grab moisture directly from the air. They're not able to do that. They need a liquid water source in order to thrive. And the liquid water source comes from things like pipe leaks that have not been cleaned up, or poor envelope construction that's allowing water to leak through a roof. And so if you imagine that mold spores get into a real dry environment because we're trying to keep the humidity down and worried about not having mold growth, it becomes like trying to dust with a dry dust cloth without spraying pledge on it. You scatter stuff everywhere and end up creating more mold symptoms and increasing the exposure of people if you allow the air to become really dry. The other thing to think about is the building insulation quality and how we construct facilities. That makes a big difference in whether or not we have liquid water present for mold growth. And if you look at a building that has good insulation properties with the outside air temperature on the left at 14 degrees Fahrenheit, the room air on the right at 72 degrees Fahrenheit, you could have great insulation or bad insulation, and that makes a difference as to whether or not you can condense moisture from the air into liquid water onto a surface where it could be consumed and used to proliferate mold. So if you have great insulation in your building, you need a hugely high level of relative humidity, over 95%, before you're going to start getting condensation on a surface and having mold growth. If the insulation quality is poor, then you could start to get condensation, in this particular example, at a relative humidity of only 35%. But really, if you have the same temperatures, it's really the difference in insulation technique that tells you whether or not you're going to have mold, the possibility of liquid water and then mold present. And so we think about where should we have that relative humidity at? What is the optimum level? And we've got competing goals. We want to protect our building. We don't want to have condensation and rain in the building, kind of, fears. But we need to protect occupants and keep people safe. But the good news is that this is an easy battle to negotiate a resolution for, because we know that drier isn't always better. We're so much better educated than we used to be in the past about the benefits of having 40 to 60% relative humidity in a space and good indoor air hydration. We know that from this microbiome study that Dr. Taylor presented that we're going to have decreased infections if we keep that humidity between 40 and 60%. There are fewer allergies. There's great research showing studies on people that were exposed to barn animals in well-humidified areas that had fewer allergy symptoms, and keeps you more comfortable and hydrated in the space. wound healing is so much better in that 40 to 60% range. We don't get good cell migration and the transmission of good healing going on if the body and the wound area is all dried out. And ASHRAE has done great research with Standard 55 to show that we have increased thermal comfort when we maintain that healthy relative humidity range. And if you look at the charts for sizing HVAC systems and keeping in mind thermal comfort, that 40 to 60% relative humidity range is right in a great spot in the band of comfortable conditions for people to be in. The next slide I want to show is a chart that was published in 1985. Schofield and Sterling worked on this, and they gathered a whole bunch of different papers and research and put together the impacts of humidity on bacteria and virus and chemical reactions. And I remember seeing this years ago early in my career. It was very influential to me to see that 40 to 60% range and think, wow, if we just maintain that, we could really make a difference. And since this time of this publication of the chart, we have even more relevant research that has been published that's contributed to our knowledge and backing of that. So we can decrease building energy usage with proper humidification, which is something that could be a little counterintuitive to people. Sometimes people are thinking, gosh, yeah, I'm going to run a humidifier and that's going to use up a lot more energy. But hospital air change rates are kept high because we think, oh, that's going to yield a better indoor air quality. But what matters a lot is that we have a great motion of air through the space, going from clean to dirty, not just air changes. And when we get a lot of turbulent air blowing around in a space, we're mixing up all these infectious particles and spreading them around everywhere, exposing more people. So if we know that lowering the air change rate could reduce infection by not spreading those particles, and that we can do that if we keep that humidity at a great level, we can save a whole bunch on fan energy costs. And there was a great paper that Travis English from Kaiser Permanente published at the ASHRAE meeting in 2015, where they did an experiment in some California hospitals with natural ventilation a natural experiment, and the findings were that you could reduce the air change rates from 6 air changes to 2 air changes based on ASHRAE Standard 170, and you would get the 70% savings in fan and reheat energy costs for a VAV system that has an air side economizer in it. ASHRAE has also sponsored Research Project 1515, which concluded that the VAV room terminal units could be turned down to 10% of the full CFM flow without losing control or creating indoor comfort concerns. So they had great success with this. They even found that a lot of the complaints that they'd had of overcooling went away when they studied this approach to lowering the air change rates. So I wanted to talk just a moment about some of the myths and legends that go on with trying to maintain indoor relative humidity levels. This was a picture from a project that I worked on, literally a piece of cardboard saying, do not remove this, taped over a diffuser. And my point in showing this is that people want to be comfortable, and they're going to do what it takes to be comfortable and feel good. They'll do a workaround or whatever, and they want to get rid of the complaints. Operations and maintenance staff are so busy. I work with a lot of people in facilities, and they are always striving to be more efficient and find better ways to keep up with all the tasks that they have. But like many of us, they're getting pulled with more to do than they have time with. And things have changed now. We finally have justification for making humidification systems a priority. We can shift money to support operations and maintenance for a hydrated indoor environment, and we're going to see a financial payback for it. We just need to shift the dollars and the emphasis for that. But there's some stories that swirl around about how hard it is to maintain humidification systems, and I've been talking with a lot of facilities folks about this and trying to better understand those issues, and I think there are cases where there's been equipment failures, there's a lack of staff and resources to properly maintain equipment, there's a lack of perception on the value of it, And also, sometimes there's just weird things that are going on with the way the system was originally designed or the way that it's controlled. And I like to think that this greater emphasis on the value of maintaining at least 40% relative humidity is going to lead us to better equipment design, better awareness of designers on how to do a good job, and more resources for people to maintain this because of the great impact that it's going to have on patient health. And we have some great changes that are coming on the horizon. The microbiome results are going to get evaluated now with respect to what those minimum humidity levels are. We had a presentation of some of this information shared with some members of ASHRAE Technical Committee on Healthcare Facilities at the last conference, and we're going to be talking about it at our upcoming conference here in Vegas in January. So we may see some changes come forth from that. Also, there was a proposed Addendum M to ASHRAE Standard 170 that was to allow adiabatic high-pressure water atomizing humidification. And there are some provisions for making that happen, using RO water, UVC lights, submicron filters, and continuously circulating the water and an ability to drain it down so we don't have any stagnant water or storage. And the ASHRAE Standard 170 Committee met in Atlanta late last week. They reviewed all the public comments on Addendum M, and happy to say that that has passed. And so with a little bit of paperwork follow-up, that should be published very shortly. There are also some really great research projects that ASHRAE has done and they are continuing to do, and others in the field are doing. I've read some really great research of study of droplets that are leaving the human body. I used to think that when you sneeze that it was a whole bunch of particles that came out, or that you coughed, that was it. But it really comes out of your body, if you could just imagine, in more of a liquid form, and then the environment influences how those droplets are formed. If it stays more liquid or larger particles, or if it desiccates some, dries out, and starts to spread more. And so some great visualization and research to better understand how that environment really influences the spread and development of particles. The Facilities Guideline Institute and ASHE and ASHRAE have also got together recently and jointly sponsored a research project to look at all the requirements that are in Standard 170 and go back and figure out what the research basis was for those, if it was more anecdotal or if there's published research, is it peer-reviewed, and basically rate the quality level of all that and identify any gaps where you might want to do some more research to learn more or to validate what some of those requirements are in the standards. Lastly, we're going to see some improvements in the humidification systems as the I guess, spectrum of what people know has changed and the importance of it has grown. People are going to respond to that with greater emphasis on new designs and new installation techniques to save energy and to give us a better opportunity to maintain and operate these humidification systems. So that concludes the piece that I wanted to go over here. We've got another poll question that we're going to push out to everybody.
Great, and thank you. It is time for our second poll question today. So please let us know, what is the current state of the humidifiers at a facility you are involved with? Facility has never had them, turned off from day one, turned off after having problems, running but with difficulty operating or maintaining the system, or running great and humming like a bee. So we'll leave that question up for a few seconds. If you could please get your responses in. All right, and we'll go ahead and show those results. And some mixed findings here, but a small, the most seems to be going towards systems that have them running, but difficulty operating or maintaining them. So speaks to some of the challenges there. Thank you for your responses, and I'll turn it back over for the continuation of the program.
Great, thank you. So lastly, I'd like to talk about some actionable items regarding indoor air quality. as well as the potential financial impact. Going back to that 250-bed hospital we looked at, this summarizes the costs associated with the total hospital-acquired infections in 2015. That number is about $15 million. When you tie that in with the total associated costs, on the left hand we have the operating revenue with no loss, and then as we go to the right, we add the cost of the HAIs. You see the HAI direct costs from treating the patients, and that number is significantly larger than the actual CMS penalty, as we discussed earlier. To the farthest right, we see the lost revenue from patient days that we projected from the increased length of stay. So bringing all of this lost revenue in, we created a financial projection of implementing a more accurate humidity system into the hospital. The assumptions aren't listed here, but we see a large return even on the first year, 500% return on investment from installing and getting up and running a new air humidification system that meets the specifications that we are suggesting today. So it does show to be a good financial investment, as well as having a very positive impact on the health of the patients. So what would the next steps be for this? First, we have to record the infections. Unless we have an accurate starting point, we really won't know where to go or what the effect of implementing a new system is and what the return on that is. Additionally, we need to know what the indoor air quality is throughout the facility. It can vary significantly through the building in different parts, different floors, obviously from the basement up to the top floor, but also on a horizontal basis. So having accurate monitoring systems there also is very important. Then one should identify weaknesses in the building and the HVAC systems that exist. So as we discussed, from an insulation point, but as well as the air circulation and the HVAC that exists today. Then installing appropriate humidification systems. There are new energy-efficient, hygienic systems. Many hospitals, many systems have very outdated systems that don't provide the same level of control that would be required for optimal patient health. And then once these are installed, you have to continue monitoring the changes both in the room air and the patient outcomes to properly assess the impact of the investment. I'm going to hand it back over to Dr. Taylor for some final comments.
Hi, everyone. This is Dr. Taylor. Just wanted to close up. And actually, hot off the press as of yesterday or the day before yesterday, the FGI and ASHRAE has now approved the adiabatic DL system for use in hospitals. And this came about as Sloan Kettering implemented an evaporation humidification system, and the success has been overwhelming. So that's a hot off the press update on this topic. Anyway, I thank everybody for listening, and thank you to the speakers and to the American Hospital Association. So now we're going to have about 15-20 minutes for a question and answering session.
Hi, this is Lindsay. If you can, please submit your questions, and we will begin the Q&A session. And you can submit those under the Ask a Question button on your module there on your screen. So our first question has to do with RH in patient rooms. And the question is, we don't monitor RH in patient rooms. Should we start?
So this is Dr. Taylor responding to that. And the short and long answer is yes. We should be monitoring relative humidity in patient rooms, given that it is a key indoor condition for patient well-being. Thank you.
Great, thank you. There's also another question about the American Society for Healthcare Engineers, ASHE. I'm guessing from the question, they now allow operating room relative humidity to be decreased to 20%. Could you talk a little bit about why that is a current guideline and why that's been decreased?
So this is Dr. Taylor. I'll talk about this, and then Ms. Hannigan, you may want to as well. So ASHE has implemented the ability to get an amendment to lower the current minimum level of 35% down to 20%. And their justification for this is that we no longer need 35% because we have better cauterization equipment in the OR, so we don't have to worry about sparks igniting things unintentionally in dry air. Another factor is that the clinical staff are usually gowned in multiple layers of cloth or lead shields if there's fluoroscopy, and so it's much more comfortable for the staff to be in a cool, dry room. Unfortunately, the considerations don't take into account patient well-being, patient healing, patient wound care, and as we've been talking about, patient infections. So, Ms. Hannigan, do you want to add anything?
Yeah, I think that's great. I know there was a lot of discussion at the time about whether or not the space was used for short-term care or long-term care, and the fact that some of the spaces were shorter-term was deemed at the time to be very strong in contributing to them lowering that humidity limit.
Thank you. And we have a lot of questions coming in. Thank you. Keep those coming. Again, we will follow up with the ones we don't have time to discuss today. So here's a question. It says, I understand only the U.S. permits direct boiler steam injection into the airstream. Have there been studies done on the health effects of this? Is there any research being done on using clean steam humidifiers rather than the chemical-laden boiler steam? 99% of the jobs I'm involved with are using direct boiler steam injection.
So this is Dr. Taylor. Unfortunately, there are very few studies that actually look at the occupant health in response to humidification systems. So if we look beyond comfort criteria, such as dry skin or dry eyes, and actually look at health effects, that research is begging to be done. We need to do it. However, at this moment in time, I'm not aware of any studies that are looking at occupant health and different humidification systems.
Great. Thank you. Here's another one. It may be somewhat related, but just asking if there's any studies or information on failing humidification systems causing pooling inducted systems. Could the pooling cause additional problems?
Ms. Hannigan?
Yes. I have heard stories of humidification systems causing it to rain in operating rooms and all kinds of scenarios. And when I dig down deeper, I find that oftentimes there was something going on in terms of the control of the system or in the installation. I remember distinctly a call about a project where it was raining in the hallway outside of an operating room because the humidification system had saturated the duct and it was pouring out. And ultimately what was found is that the duct was dry, that someone had accidentally done something up in the air handler and punctured part of the humidification canister, and that it was leaking out. And yet the story kind of gets told and the myth goes on that really there was rain in the ductwork. But I know that the control is a big issue, and getting control loops tuned, understanding that these humidification ranges that we're talking about are also very temperature dependent. And so we talk about 40 to 60% relative humidity, but it also matters what the temperature is in the space and what the dew point is. And having a consulting engineer coupled with an architect of your building environment and your envelope that really know what they're doing and can control the system correctly and get it designed right.
Thank you. That's very helpful. Someone asked a question about the microbiome study that Dr. Taylor, you shared early on. Are the results available, and could you talk a little bit about that?
Hi. Yes. So for everyone who's registered for this webinar, you will get a printout of these slides. In addition to that, within 48 hours, we'll have a link to download a white paper that talks more about the microbiome study. In terms of peer-reviewed journal publication, the study is in press. There's the room monitoring and the bacterial spread components have been published, and again, we'll send out links to those. The HAI part is in press, however, you'll get the preliminary information within 48 hours. Do we have more questions here?
This is Tracy Hannigan. I see one here that talks about addressing fuzzy ducted systems, and says it seems like it's a serious infection control issue. I assume what's meant by fuzzy ducted systems are line ducts, and yeah, that's a pretty bad issue. I'm looking at a facility right now that's got some lined ductwork, and that just creates an environment where if that were to get wet with liquid water, you could have mold growth, and I've heard of people becoming sick from it, and so that's the primary reason why ASHRAE Standard 170 doesn't allow line ductwork in healthcare facilities anymore.
Hi, this is Lindsay again. Sorry, I think my call dropped there for a second, but I'm back and ready to keep going with the questions. So one of the questions is it difficult to maintain proper humidity in an more difficult to maintain proper humidity in an air-conditioned or heated environment?
Ms. Hannigan, do you want to take that one?
Sure. Well, some of it, I could joke that it depends on where you grow up and what part of the country you're used to working in. In the Pacific Northwest, we deal a lot more with the heating environment, and it's not that humid in this part of the country, and people that live in the Southeast and the Midwest tend to encounter situations where you've got a lot more humidity coming in the indoor air. But when you're talking especially about operating rooms, it doesn't matter. They're all going to be air-conditioned space, and I think it's more straightforward to add humidification to a space that you're trying to heat, where you've already got that air dry and you're just adding the moisture to it. When you're air conditioning, you are trying to cool that air, and that causes condensation. You're pulling moisture out, and then you've got to reintroduce that in. And so I think it's a more challenging situation for a designer when you're doing air conditioning to try and maintain that relative humidity range.
Thank you. And there was a couple questions, follow-up questions about the RH monitoring. So could you talk about how facility managers are supposed to and expected to monitor RH? One question came in, concern about monitoring it in every room by hand, or versus with if your BAS that isn't maybe functioning properly.
Ms. Hannigan, do you want to do that?
Oh, sure. I think the value in monitoring relative humidity is really to get a baseline and compare what the infection rate is in a facility if you aren't maintaining the 40 to 60%, and then if you make modifications. There's not a lot of benefit to just monitoring it just to measure it, unless you're going to try and get a baseline or do something different, or if you have a system then where you can control the humidity. And there's a lot of places that just don't have those systems installed right now. And if we have that information and we know what that level is and we correlate that to the infection rate, then we can see the improvement, and you can measure it, and then you can control it and change it. And it's not something that every facility is just going to be able to go out and do instantaneously, but it's a matter of changing our thinking about how valuable that information could be and what kind of a difference it might make for the outcome of a patient in your facility if we know that we're maintaining that and we can control it because we have the feedback information.
This is Dr. Taylor. Thank you, Ms. Hannigan. I see a question here that's very relevant, which says it's important to note that relative humidity alone is insufficient. You need temperature data to determine the dew point. I just wanted to say that in the microbiome study, we did monitor temperature, and when we ran the multivariate statistical analysis, temperature was not as highly significantly related to patient infections. It was the relative humidity. this takes me to another point, which is that sometimes in the literature you will see studies that talk about the low temperature in the wintertime being correlated with influenza. So I've done some analysis of those statistics, and it looks as though it's not so much the cold outdoor air, but it's the heated indoor air, which is consequently dried out, that's probably responsible for the seasonal influenza outbreaks.
Interesting, and thank you for adding that note. We probably have time for a couple more questions. So one is, from a health standpoint, what is the optimal level of humidity?
This is Dr. Taylor, 40 to 60%. The studies actually going back to 1985, Mike Schofield, Sterling, Avondale, looked at 9 clinical studies, and the results from that literature review, their conclusions still hold today. So 40 to 60% is ideal.
Thank you. One question is, do you advise starting with patient room humidity if that can kind of be done on its own, or does it really need to be the entire facility?
Well, that's a good question. Ideally, the entire facility should be monitored because patients often don't stay in their rooms. They're taken here and there for diagnostic studies, CAT scans, x-rays. The people come in and out from the nursing stations. So not only do the patients not always stay in their rooms, but the airborne pathogens can also travel around. But at this point in time, given where most hospitals are with humidification, addressing the patient room would be a great start.
Great, thank you. With that, I think we are done with the amount of time that we have for questions. There are many questions that came in, so those will be provided to our speakers, as well as your contact information, so they can follow up offline if you have a question that wasn't able to be responded to. So as a reminder, in the next few days, all attendees will receive an email with a link that will include the archived webinar session, and you'll also be able to receive a version of the slides through that. If you would like to download today's slides from the presentation, please click on the Materials tab. Thank you all for joining us, and thank you, Dr. Taylor, Ms. Hannigan, and Mr. Tossi for sharing infection prevention strategies to reduce HAI costs by 30%. Thank you again for joining. This concludes today's program. Have a wonderful afternoon.